So thank you again for the invitation. It's been a great conference, and I go to many, so this one stands out, so congratulations. So last night in his opening address, William Schwab said this. He said, "This will not be a passive conference." So I hope by now you know that's true. He wasn't just joshing you. It's true. And we're going to continue along with that theme. We're going to try and make this very interactive and with a real emphasis on giving you stuff that you can take home and use tomorrow, or even tonight if you work on the night shift, some of you. What we're going to do in this session is try and bring the whole bunch of the information you got today together in some sort of synthesis, more digestible form. We had rapporteurs in each of the sessions, and I flitted in and out of the sessions this morning and this afternoon to get ideas and to ask questions and so on. And we're going to try and present some overarching themes with the aid of our panelists. So let me tell you briefly the format. I'm going to make a few opening remarks. You've asked me to give my impressionistic view of what I heard today. Then I'm going to ask each of the session leaders to give a really brief introduction. They're going to give a definition of their topic. There's 3 topics. And then they're going to give a 1-minute summary of the key theme that emerged from their point of view, of course. You don't have to share that view. And then we're going to open up the floor to discussion. There's mics all around, and that's really key. Oh, and I forgot, how could I forget the patient advisors at a patient-centered conference? The patients are going to give us their synthesis view as well after the panel leaders, and they're going to be, of course, participants all along. Now, I said I'm going to invite you to ask questions, and there's only going to be 2 rules for those, aside from going to the mic, because we're taping it. Rule number 1 is please no soliloquies. Ask questions. The shorter and the tougher, the better. We want this to be a lively discussion. And number 2, you have to direct your question to one person. Please don't say, I'd like all of the panelists to answer what is the meaning of life. We don't have time for that. So, make it really directed. In my business is to ask questions, and I can tell you the shorter a question is, the more difficult it is to answer. So make them tough. Now, the one thing I'm going to push throughout is really an emphasis on practical examples. I warned the panelists, I'm going to interrupt them if they're sounding too academic. I don't want to hear about academics today. I want practical stuff that people can use. So that's going to really be our emphasis. And the last thing is I'm going to break from tradition, because doing patient-centered care is about doing things differently. And I'm not going to ask you to turn off your phones. I never do that anymore at conferences. I'm going to ask you to keep them on, get on Twitter, get on Facebook, pin on Pinterest, whatever social media addiction you have. I'm a Twitter addict myself. But use it, share your knowledge as widely as you can. That's what it's all about. So use your phones as you see fit. Check up on your kids, etc. That's all fine. People in healthcare never do one thing at a time. They multitask. That should be accepted. So let me start with a couple of opening remarks, my impressionistic view of today. I feel that in healthcare, and I've been writing about healthcare for almost 30 years now. I started right out of kindergarten doing this. And I found that over time, things are getting better, but in healthcare, we still tend to get caught up in the issues of the day, in the current issues. How many people are waiting in the ER? How many bed blockers do we have? Everything that's happening now. We tend to lose sight of the bigger picture. And one of the things that I find frustrating is we never, or almost never, stand back and ask really fundamental questions. And those are often the most important questions. And to me, the most basic and important question that we have in healthcare, whether in Canada or anywhere in the world, is what do patients want? We should sit down sometimes and just mull that over lunch among ourselves. And I think that's ultimately the question you're trying to answer. That's why we're doing this move towards patient-centered care. Obviously, patients are not getting what they want. That's the fundamental premise here. And I think a lot about this question, and my job is to write things in really a pithy fashion. So I have an answer to that question, and I've boiled it down to a sentence. And my answer is that patients want care that is appropriate, safe, accessible, and affordable. Seems pretty simple, but it's not, as you know. But we spend $207 billion a year on healthcare in Canada. I don't see any reason why we can't deliver on that with the money we spend. Now, to deliver that kind of care, appropriate, safe, accessible, affordable, You need to have the right people in the right place at the right time. Healthcare is all about people. 70% of our spending is on people, 100% of our care is by people. We can't lose sight of that. The machinery and all that, that's just plumbing. It's not important in the grand scheme of things. Having the right number of people is important, and we talk a lot about numbers. Do we have enough doctors? Do we have enough nurses? But it's not all about numbers. To me, it's about quality and appropriateness. Those are far more important than numbers. And most important of all is, how do you deliver? How do you give the people the tools to deliver the care patients want and need? So to me, if there's an overarching theme from these 2 days, from last night and all day today, what I listened to, it can be summed up in a single word. And it's a word I heard at every single table I dropped in on today. And that word you can probably guess. It's the word respect. It's all about respect. That's what patient-centered care comes down to. Respect has to be the starting point for care. There's no question about that. But there's another word. And I didn't hear this word uttered singularly, but it was implied in all the discussions. And that word was inclusion. The biggest healthcare workforce we have in Canada is not nurses or doctors, it's families. Families, there's about 4 million family caregivers in Canada and about 1.1 million paid care providers. So it's an army of unpaid caregivers. And we kind of forget them, we take them for granted. But the message I'm hearing today, and more in the health system, is that patients want to be full partners in their care. They don't want the crap stuff dumped on them. They want to be full partners in their care. They also want to be part of the process of reform, of changing the system for the better. And I thought that e-patient Dave, he said a lot of interesting things, but I thought he said this really well. He said, patients are a competent, valued resource. Let them help. We don't often let patients and families help themselves. We do the opposite. We make it difficult. We put up barriers. No successful industry can afford to ignore its clients. But that's been the modus operandi in healthcare for a long time. What we've done in healthcare is behave foolishly and in an undignified and disrespectful manner for a long time. That's what you're trying to change. So I come back to that word respect. Respect has to be the starting point for care and the starting point for all public policies and for all workplace rules. We have to make it easy for people like you in the workplace to deliver care in a rewarding and respectful fashion. Again, that's what you're talking about here. Healthcare is a hands-on, hearts wide open business. That's how it should be. It's about relationships, not about plumbing. There's only one thing that distinguishes good healthcare from bad healthcare, and that's good people. And that's what we've gathered here today, I think, is the good people. That's why you're here. You're not here because you're indifferent. So patient-centered care, for me, bottom line, is about doing everything in our power to allow the good people to be good, to excel, and above all, to excel at respect. So I'm going to introduce each of our panelists. I think you know them all and they've been introduced briefly. So I'm just going to give them a brief introduction before their 2 minutes and let them fly. So who will we start with just randomly? How about Leslie? Are you ready? We'll put you on the spot. So Leslie Flynn is the Interim Vice Dean of Education at the Faculty of Health Sciences at Queen's University. And as you know, she was leading the session, Interprofessional Education. So she's going to give us a definition of that, and then just a 1 minute, what did you retain from your talk as the most important theme?
Is it on?
Yep.
Yes, thank you. So the people who actually attended the session know what the definition is that I'm going to provide for you. It was developed by the Centre for Advancement in Interprofessional Education, which is a centre established in 1987 in the United Kingdom. And that definition is, interprofessional education is those occasions when members or students of 2 or more professions learn with, from, and about one another. Why? to improve collaboration and quality of care. And that's what we discussed in our session. The thing that I thought was really terrific in our sessions was that I learned that all across this country, all across Ontario, there are many, many examples of interprofessional education already in place. So I thought that was terrific. It was captured in one person's presentation of the benefits and the good outcomes. Someone said, we all win with interprofessional education. The patients, the care providers, the system.
Great. You've set a good example, right on time. It's very good. So next we'll jump to, how about Cynthia? So Cynthia Phillips is Manager of Interprofessional Collaborative Practice and Education at KGH, Kingston General Hospital, because I told them we weren't allowed to use acronyms or I would cut them off, so I can't do it myself. And she, of course, was one of the leaders of the collaborative practice session.
Thank you, Andre. The interprofessional collaborative practice model, for those of you who were at the session, heard how the model was designed by KGH staff and physicians. We had representation from all services and disciplines within the organization to come together, and our mandate was to design, implement, and evaluate a viable model of care delivery that was patient and family-centered, high quality, safe, and cost effective. And in our sessions today, we heard some great examples of collaborative care that are happening in all the organizations, as well as the challenges which seem to be the same no matter where we go.
Okay. Do you want to give us one example? Because you have time left. Give us one really example that stuck with you that you heard at one of your sessions.
Of a challenge?
No, of a good thing. We'll start with the good, we'll get into the bad later.
Really, it's the focus on the interprofessional team working together with the patient and family. And everyone is there for the good of the patient and family, partnering with them, and just so many different ways, whether it was in home care, whether it was in an acute care institution or a rehabilitation center. I think we're all striving to achieve the same goals.
So it's that seamless journey of care that you're trying to get.
Yes.
Okay, great. So our third session, and I know this one was really popular, so they need no introduction, but I'll give them one anyhow. Rosalind Marshall, Neuroscience Nurse Manager, and Bernard Robertson, Director of Patient and Family-Centered Care, both of them from Georgia Health Sciences University. And one of you is going to give us a definition, and the other one a pithy summary of your session.
Okay. Good afternoon. Thank you. In our session, we learned a lot about what really is patient and family-centered care, and we sort of come up with all of us had the concept of patient and family-centered care, and it really is an approach to how we deliver care, how we plan care, and how we evaluate the health care that we all as healthcare providers provide in some way or another. And it is also a mutually beneficial partnership, a partnership between the patient, the family, and between the healthcare providers to ensure that we are meeting their goals of what they expect in the healthcare environment. And now Bernard will share a little bit about some of the highlights from our session and what we learned.
Well, hello there. Well, our session was mainly about the journey that Georgia Regents Health System took when we started with patient and family-centered care and talking about some of the challenges that we had and how we overcame them. But it was also about looking at the 4 principles of patient and family-centered care as the basis for everything that we do when partnering with patients and families through service recovery, through service excellence, and even just beginning the process and how we bring patients and families on board with us. It's more than just starting with what our thoughts are, but also when to bring patients and families on, which is at the very beginning. So we talked a lot about how to do that.
And those 4 principles, if I did my homework, were dignity, information sharing, participation, and collaboration?
Add respect.
And respect. There you go. Well, that's 5, but that's American math for you. So, there you go. Now, I'm going to ask each of our patient advisors. We'll start with Glenn. Glenn Uthwaite is a patient experience advisor at Kingston General. Give us just a sense of what you got from today that's really important take-home message that you want the folks to bring home and implement.
I think the first thing is really looking at who is a member of the team and being open to including everybody as a member of the team. And I think that that's really important. And I don't think that we go far enough to include everyone. The second thing is that the patient has a responsibility as well in this whole process. And they have a responsibility, I think, to acknowledge the care that they're being provided and the services that are being provided. So, for example, housekeeping or environmental services, they provide a really essential service. If they don't clean properly, then I'm at risk. And I think that they have to be told that they're important, they are part of the team, and that as a patient, I really appreciate what they're doing. So those would be the two things.
So you're saying the team is much more than a medical team. It's the
Absolutely.
food services, it's the janitors.
It's everybody.
Yeah.
It's absolutely everybody.
Good. It's a good message. And last but not least, of course, Carrie Stewart. Stewart is a patient advisor with the Southeast Regional Cancer Program of Kingston General Hospital. Carrie.
Thank you and good afternoon. I'm just going to mention a couple of the things that have resonated with me that I've heard today. The first of that being that patient and family-centered care is really just good common sense. It's nothing more complicated than that. And that this is what we expect of all healthy relationships in our lives, with our partners, with our children, with our employers. So certainly we should expect that in our relationships as caregivers and patients. Another piece that resonated with me was the comment that we need a 7-day-a-week model of care so that patients get the same care on Saturday afternoon that they get on Tuesday morning. And finally, the piece would be get started. Don't wait for the stars to align and everything's perfect before you get started. Just jump in somewhere and get started. Part of the reason for that is that you have patients right now. And if you wait until everything's ready, those patients right now will have come and gone, and tomorrow you can make life better for them. Which leads me to my favorite expression, a quote from Jerry Garcia that goes like this: somebody has to do something, and it's just incredibly pathetic that it has to be us. So I would encourage you to help me paraphrase that to, it's just incredibly exciting that it gets to be us.
So you're witnessing something unprecedented at a conference. First of all, a quote from the Grateful Dead. And now we're going to have a full hour of participation from the audience. You just don't have to be vessels and receptacles of information. Get out there and share it. So I'm going to invite you to come to the mics, and I'm going to start off with some questions. And it'll be really boring for you if I ask all the questions for an hour, but I can do it. I have lots of practice. But there's mics on either side of the room. Wave your arms and stuff like that. But oh, not to worry. I'll come to you in a second, but I'm going to get first dibs. But go stand there, and I'll ask you in a second. But I want to start. I want to start with, to me, is the big question, because you had said, and it's a very good point, that this is common sense. But as we hear often, common sense isn't that common. So I want to know. Everything I heard today was common sense. Why haven't we done this? What's been the holdup? Maybe Bernard, you can start with us. What's the single biggest impediment to patient-centered care? Is that we're fearful, we're stupid? What is it?
We're fearful. A lot of folks are fearful. We have excuses for everything. If you want to go to the beach, it costs too much. We don't have money to put gas in the car. And patient and family-centered care has been somewhat the same way. A lot of folks are like, I don't know where to start. My people don't have enough time to do it. We need to really just kind of sit back and wait and see what needs to take place. But like she said, we just have to do it. We just have to get out there and do it and look at those barriers as challenges that, you want to set goals to meet and just go out there and do it.
And Glenn, I want to ask you, I'm going to come to you in a second, don't panic. But Glenn, we had a good discussion at lunch, and you've been in the health system for a long time. So I want to get a sense from you. Because we get a sense that things are so slow changing, but is it getting better?
Absolutely. Absolutely. I'm a frequent flyer, so I spend a lot of time in hospital, so I get a chance to observe the changes on the units, and I'm also on a variety of units, so I get to see how each unit operates. And I can honestly say that over the past few years, there has been significant change in attitude of the staff, in how they relate to me as a patient, and how they relate to my family when they're involved. It's a much more positive approach, and it's a more warm and welcoming than it used to be before, and certainly they do come to you for your advice, and they talk to you about what changes or what they're looking at, and give you an opportunity and your family to interact and provide your input into those decisions. I think that the thing that's missing still is that there aren't multidisciplinary rounds where physicians and all of the disciplines are there and you can interact with all of them at the same time. But certainly there's been major progress.
And give me a practical example, 12 years ago compared to today being in a hospital bed. What's one thing that's really different that you're really happy about?
Well, one thing that's very different is the attitude of the nursing staff. 5 years ago, 4 years ago, you would hear the staff in the hallway bitching about things that were happening on the ward and were very unhappy. Morale was terrible. And if a nurse needed someone to come and help her with a patient, she almost had to beg somebody to come. Whereas today, when I hear what's happening in the hallways, it's very upbeat, it's a positive approach, and staff are offering to assist other staff with patients who are providing or require heavy care. So I think that that's one very significant change within the organization.
And Leslie, I want to ask you one more thing. I want to get in my digs up front. This 7 days of week care, that really resonated with people, and I heard that again at the sessions. Why don't we do that? The patients want it. We know it's necessary. Why doesn't it happen practically? What's the excuse, if not the reason?
I'm not sure that I have the answer to that question.
We're not going to let you leave here without one.
My suspicion would be that we all like to think that we're going to have time off, that we work really hard in our professions, we deliver care, and that we'd like to have a weekend too, or we'd like to have a day off in the middle of the week. So I think it's probably a historical attitude that's developed over years. When you work in the healthcare system, and all of the people in the audience are involved in the healthcare system, we all know that care changes on the weekend. It is not the same delivery of care. And so I think it's a very, very good and rich suggestion. But I think it'll be difficult to implement.
But take my mom. Say my mom has a stroke on Friday night. It's really essential to have quick response to stroke care. Why does she have to wait for Monday for it to start? She's going to have a worse outcome. How is that fair?
So I would suggest your mom probably would get the same care. Some kind of acute crisis, we always have on-call staff, and they would deliver that kind of acute care. That's not the problem. It's the problem when it's a Saturday and someone could go home if they had the appropriate care at home and maybe a family meeting, and that kind of care, which is more run-of-the-mill, day-to-day movement through the hospital. That acute care, I think, happens, whether it's the middle of the night or whether it's the weekend, Saturday or Sunday. That's not the problem. It's the keeping things moving that we do Monday to Friday, which just don't happen on Saturday and Sunday. The elective kind of process.
Rosalind, I saw you almost jumping out of your chair. Get in on that one. Why don't we do 7 days a week care?
Well, I'm really passionate about that. When you said stroke care, you know, I'm the manager of neuroscience. So I'm like, yes, we do, we have to.
I said the right thing.
Yes, you did. Yes, you did. So we do take care of our patients 7 days a week when it comes to stroke care. And you're absolutely right. When it comes to certain disease processes, certain things going on, we have things in place. But I will say that just over the past year, we made some changes so far as stroke care, like services like ultrasounds being done 24 hours a day, 7 days a week. On the weekend, not being able to get those tests done so that the patient can be discharged on Saturday and Sunday and not have to wait till Monday. So those are the kind of things that we need to look at in healthcare throughout all of our facilities, no matter whether you're in the United States, Canada, England, no matter where you are, because healthcare does not stop on Friday and you come back Monday morning to pick up. It's a continuous process. The families do not need to wait until Monday morning to be educated about the care of their loved one. So we always talk about, planning for discharge starts on admission. We need to remember that everything so far as working toward that patient's discharge starts on admission. So it's a continuous process. We don't wait until the time of discharge to get things done. We're continuously planning, and we need to continue to look at what we provide in our healthcare system so that that care is available to each and every one 7 days a week.
So Carrie, you brought this up. Give me an example of where it's not working. Who's not getting 7 days a week care? You work in cancer. Are there examples in cancer where it's not working?
Well, when my husband was ill, every incident that he had occurred after 5 o'clock on Friday and before 9 o'clock on Monday. So I don't know what the process was like for him, but for me it was really frustrating. All of the players weren't there. All of the tests couldn't be done. It meant we often spent long weekends in an agony of suspense, waiting till we could get the information, often to find that what we thought was a big event was a very manageable, relatively minor event in his journey. So, it was a lot of stress that the whole family, not just the patient, was under. And I couldn't help but think, we have police officers that work 24/7. We have firefighters that work 24/7. We have emergency responders who work 24/7. How come a hospital kind of shuts things down a little bit between 5 o'clock on Friday and 9 o'clock Monday morning? Just a question.
We have Tim Hortons Donuts 24/7 too, so maybe that's why there's a lot of stroke care. I'm not sure. Okay, now, you've been very patient, but we still have 56 minutes, so I'm close to an hour.
You asked that one already. You asked that one already.
Okay, you could sit down. Well,
A question for Bernard. Bernard, I represent a group of individuals, using the words of Dr. Schwab, I guess, as wrecks. Bunch of old dogs walk in a line, and what's in your bag of tricks to get this out to the old dogs?
Well, we use other old dogs. We use physicians who have been practicing for years but really understand the practice of patient and family-centered care, and we use them to talk to our experienced physicians. I'll give you an example. We were in the States, we have what's called HCAPS, which is Hospital Consumer Assessments for Healthcare Providers and Systems, and it is
What?
a CMS mandated. He said I couldn't use the acronym, so I had to give it to you. But just trying to educate our physicians and a lot of our older physicians on what HCAPS is all about. Excuse me, I got to use this. It's long words. But what HCAPS is, when I tried to train the physicians with the tools that we use, they were not receptive. But when I got other physicians to teach the classes using the same materials, it was wonderful. Creating just a video on what HCAPS and what it means for the physicians, they loved it. It's a 3-minute video that got them started, and then they came back and said, oh, we want one every other week. So using physicians who have been there and who have been practicing and who have practiced patient and family-centered care their entire career to help us get the message out, that's the approach that we've started taking.
Thank you very much.
and Cynthia, do you want to jump in on that? This whole question, how do you teach the old dogs new tricks? How do you get doctors or nurses who've been doing the same thing for 25 years to switch to collaborative practice? That must be your biggest challenge.
It is definitely a very big challenge. And I think just, as I was saying today, is to be patient, to know that practice change takes time. And when people see the results of working together as a team, it's much easier when we do it together. But it continues to be a challenge. I can't say that I've actually conquered that one yet.
But you must have a success story that keeps you going. Give me an example again.
Well, we've had lots of success stories, actually. The documentation, to me, is one we heard about a lot in the room today, interprofessional documentation. Before the model of care, we had different providers charting in different sections of the chart. Very difficult to follow the progress and consolidate the information when you're trying to make a decision. And I heard loud and clear today that people really find that a benefit, that it's much easier, and they're feeling more part of being a team. But again, there's still challenges with buy-in with different units, different positions, and people continue to resist. But over time, they are seeing the benefits, and it's not about us anymore. It's about the patients and families.
Rosalind, again, I want to stick on this old dogs theme, or what do you do with those who resist? I don't want to hear about this patient-centered care nonsense. I know how to do things. I've been doing this for 30 years. And what do you do with those who don't buy in?
You're probably asking the wrong person, but I'm going to tell you my version of it. You know, change is not easy. We all know that. Probably when we moved toward a patient and family-centered care model, especially in the ICU, one of the biggest challenges was with the ICU nurses because they like control. And having the ICU open and no visitation hour, moving toward family presence, and not having the buzzer to ring to say, can I come in? The way that I handled that was I took the doors down. The doors are down, so there is not a buzzer to ring to come in. I mean, so that took care of that. That was number one. So now we have moved toward a model where the families and the patients actually say to us, I really don't feel that I'm in an ICU, because all that anxiety I had before, when I had to ring the buzzer to come in and I'm standing outside while the physicians are making rounds, I don't have that because I'm a part of rounds. I'm here when you do bedside change of shift report, and I don't have to wonder what's going on. So now it's a true partnership because I am a part of the care. So when I said to the nurse, I'm taking the doors down, she said, well, what are we going to do? I'm not going to be in control. I said, exactly. It's not about you anymore. It's about us being partners with our patients and families. But you have to, I'm sorry, I'm long-winded. You have to listen to those fears and anxieties that your staff may have, because some of those fears and anxieties will be your greatest change agents and will eventually be some of your greatest champions in supporting patient and family-centered care. And if you don't know what those fears and anxieties are, you can't address them.
And Glenn, I want to, again, bring in this patient perspective. What do patients think of the old dogs, of the people who, I've always done it this way? Do you sense it? Do you know it? What do you do about it?
Well, you definitely sense it. And you see the difference between the physicians who are more progressive and are open and integrating that concept into their practice. The old dogs that you deal with, what you have to do as a patient is you have to challenge them and try to tell them or get the message across that what you want is something beyond just what they're saying. And you want to have your say in the decisions around your own care. Some of them are not very happy about that at all. Some of them begrudgingly will give in to some degree. But I think it's just a constant battle of challenging them, and it's not only the patient that's challenging them, they're being challenged by members of the healthcare team from the other side as well. So hopefully over time they will actually come on board and change.
And Leslie, I want to ask you, is it, I keep using this term old dogs because it was catchy, but is it strictly an age issue, a generational issue, or is it more complicated than that? Is it cultural? Is it the way we teach people in their training? What's the root of this problem? Because I guess if we change the root, the problem will disappear.
So the answer is E, all of the above. Having done lots of multiple choice questions in my lifetime. What I'm in the very fortunate position of actually working with the young dogs. I'm working with the people who are in the professional programs now, learning their profession. So for the old dogs, what I can do is try to role model to the very best of my ability how I work with the team, how I collaborate with the team, how I involve my patients and their families. So that's what I do with the old dogs, but I'm in a privileged position of working with the young dogs. And the interesting thing is they don't have the reluctance or the resistance that the old dogs have. They're so enthused about learning about the roles of the other healthcare providers at a time when they're all just developing. So I work at Queen's, as you know, and we have implemented new programs for our medical students. Our medical students used to sit for 2 years in a classroom before they saw a patient. Now, from the very first day that they enter medical school, they're now assigned a patient, and 2 students are paired with the patient, and they follow the patient into the healthcare system. It's called our First Patient Program. We also have a program for our nursing and occupational therapy students where they're paired with patients. These are different ways of educating our professionals, our future professionals. And now what I'm going to do is turn it to Glenn, because I know he participates as a patient in those programs, and actually ask him, are those programs where we're trying to create future old dogs that are different, are they making any difference?
They absolutely are. The one program that Leslie spoke about is called My First Patient Experience. And I do have 2 medical students, a female and a male, from the first year. And what they do is that they meet with me to learn about what my conditions are, what impact it has had on my life, and then over the course of the next 18 months, they accompany me to certain or as many appointments to specialists, etc., that I can get them to. My approach is that I give them information about absolutely every medical appointment I have and leave it up to them as to whether or not they're able to participate. They have a letter. First of all, I have to phone the physician's office and indicate that I wish to bring students and make sure it's okay. I have to, or the students then have a letter that they bring which introduces themselves. What I've been really very pleased with is the way that the physicians have tended to explain what was going on and in much more detail to help the students. They've taken the students out to have discussions about some particular item that they feel that they need to discuss before they provide a certain medication or whatever to me. So they've been very included, and it's been a really good learning experience. I hear such positive feedback from them, and from my perspective, I'm going to have a physician down the road who has some appreciation for what my life is like, so that they will know what other patients are going through, and it really will prepare them in a much better way for being physicians in the future.
Okay. So new medical students in my day were assigned a cadaver, and now I see they're assigned a live patient. I would call that progress. So, there you go. So yes, go ahead.
Hi, this question is for Rosalind. The question has to do with change, because these are huge changes for some people, not all. How do you identify those people at all levels of, say, a unit or an organization who are the champions who will bring it forward?
What I did, and which was very successful for me, was to bring in my patient advisors and just start having those conversations about what patient and family-centered care, not PFCC, but patient and family-centered care would look like on our unit, and empowering the staff to be open and honest, because we don't want them to, I would much rather them share how they truly feel, empowering them to be open and honest about how they truly feel, and working with the patient advisors to come up with ways to take action for change. For example, one of the things that the staff had to change was family presence during resuscitation. We had patient advisors that worked with us on guidelines for our unit, and I don't think I could have done that by myself. But with the staff being empowered to work with the patient advisors to come up with those guidelines, it wasn't my guidelines, it was the staff and the guidelines that worked for the patients and the families, by them being empowered to share how they truly felt. So it's a collaborative approach.
The other thing is, if managers are engaged with their unit and they truly follow their unit and know what's going on, you have what I call subway leaders. And those are those leaders that are on the units that can get other staff to do just about anything. And I use the example of when Rosalind and Gary are trying to find someone to cover when we've had a call-in or something. They can call staff and they won't answer. It's Rosalind and Gary. We know why they're calling. But there's people on their units that if they call the staff, I'll be there, I'll be in. And so you have to be able to identify what those subway leaders and bring them to the forefront and let them work with the staff to create that atmosphere of change that you're looking for.
Glenn, you want to say something on this?
I just want to go back for a minute. Leslie talked about a second program with the OTs. I also am involved with that particular program and have 2 sets of OT students twice, 2 different
Glenn,
sets.
I have to be fair, OT, is that offensive tackle in football? Or?
Sorry, occupational therapists.
Okay.
And we spend time together over the course of so many weeks. The cards that I get at the end of this telling me what change that has occurred within them and how much they've learned is very rewarding. And for me, it's a way of giving back to the system, because I take a lot out of the system. So they're very enriching and very, very valuable programs.
And Carrie, I want to bring you in on this because the theme here is essentially leadership. And I wonder, you're obviously a leader, you got involved in this early. Why did you do it? Whatever possessed you to get in on this?
I didn't do it because I had an axe to grind. And I will tell you, my most recent healthcare experience did not have a happy ending. But I didn't have an axe to grind. What I did have was a series of experiences, some very positive, some not quite so. And all of them were around really hard-working, really caring people. But there seemed to me, in my observation, going with my family member through his journey, that there were just obstacles in the system that everybody working so hard in a really fast-paced environment possibly didn't have the opportunity to step back from and reflect on what was happening. And so I found that being a patient and family-centered care advisor gives me the opportunity just to add that perspective, ask the question that I think lots of people would ask themselves in the system if they just had time. And it's been amazing to me the number of times that I feel I've asked questions that maybe made people feel uncomfortable. I have never once felt that my question was resented, and repeatedly healthcare staff have stepped back and thought for a minute and said, I didn't see it that way, but I understand why you would see it that way. And then the discussion gets really deep. So it's a tough experience because if all of your outcomes in the healthcare system aren't positive, being a patient and family-centered care advisor is often a bit like ripping a scab off a big gaping wound for yourself. But it's such important work because the healthcare professionals are working so incredibly hard to do good every single day with every single patient, that the little bit that I can add to their goal setting, I think, is worth all the time that I can give them.
So tell people here, how do they find people like you? Passionate, willing to ask questions? How do you identify?
Well, networking is a big thing. I had a friend who had also had an experience, who knew somebody who had an inn, and over coffee we were having a conversation, and I said, you know, I think that's the kind of forum that would give me an opportunity to have a voice, because I don't want to grind an axe, I don't want to paint fingers, but I think I might have some insights that could help. So it was really a lot of informal networking, followed by an intensely open-minded reception when I finally made the connection with the healthcare staff. I was made to feel very, very welcomed and invited to come in and participate, as opposed to feeling like I was knocking on the door and asking if I could come in. So the combination of networking, and all of you can network. All of you know people who've been patients. Some of you have been patients yourselves, and it doesn't take a formal venue to find leaders. It takes a cup of coffee and a 15-minute chat.
Okay. So I remind you, if you have questions, come to the mics, and you have to stand at the mic. If you're sitting beside the mic, I'll assume you're sitting beside the mic. So, Cynthia, I want to bring you in on the leadership question too. With collaborative practice, there still has to be leaders, right? It's not a free-for-all. So how do you identify the leader in the team? Does it always have to be the doctor? That's kind of the assumption from the outside. How do you identify the leader in the team?
The leader changes depending on the leadership situation, and that's the big part of collaborative practice and working together. It's rotating. There's leaders and followers, and everyone plays a huge role.
And Leslie, do you want to come in on this? When you do the education, is there the assumption again that the doctor is going to be the boss and the other people don't buy in, or have we gotten past that with younger people?
It's quite clear that I agree with Cynthia completely, that the attitude is changing very much, that it's actually a relief often when there's someone with more expertise on a particular issue and someone else takes the lead. So I think, and as I say, I think the younger people are much more willing to look at their future in healthcare in a different model. So leadership will be shared, or will be different individuals on the team will take different leadership roles depending on the circumstance. And I think that's still the case. There are lots of situations in which the physician will be the lead, but not always the case.
And let me ask you the question or the comment I get from the old dogs, which is, well, if you have a team, you know, nobody's responsible, nobody takes ownership of the patient. So, you know, we just brush everything under the carpet. Is that true?
That's not at all true. There's lots and lots of literature written about effective teams, and I would recommend that you read some. Patrick Lencioni is a name that comes to mind, but there are hundreds of books on leadership, and quite clearly transformative leadership is about sharing the chair of the leader.
And I'll give you a family response as someone with parents with chronic illnesses. I don't want to read a book, I want to see it. So
I agree. It needs to be seen to be believed.
And Bernard, I see you're trying to get in there, and then we'll take a question from the floor, so go ahead.
Well, no, I was just going to say I kind of lead by example, but I also lead to make sure that I have a successor. So you have to build that leadership as you go as well. We've found many leaders in our organization to help lead patient and family-centered care. I had a group of them with me this week when I was at North York, you know, and these are folks that are very passionate about what they're doing, but they're also in the learning stage. But I share the leadership with them. I don't have to be the number one. And so we just have to make sure that we're building the capacity for future leaders while we're doing this. So I just think you just kind of have to dig deep and look and see who's willing to do what, and put them to work. Let them have that ownership, and let them take and work with the rest of the folks.
But not everybody's like you. A lot of people don't want to surrender power. That's a big issue with patient-centered care. How do you deal with the people who want to keep the power?
Well, if they want to keep the power, I tell them they really don't want to learn. And if you've outgrown the learning process, then I no longer need you. I tell folks that all the time. I mean, if you can't learn from my patients and families, you can't learn from me, it's time for you to move on, because you need to go learn from somewhere else. And folks like that who have to have the power, they stifle what you're trying to do when you're trying to build your programs and when you're trying to build patient and family-centered care. So I don't have a problem asking them to move along.
Leslie, jump in there.
Come back to me.
I just thought of something else that I would like to add about this leadership and followership. And Leslie Thompson invited Dave Williams to come to speak to us when we had a week in January sharing and celebrating our interprofessional collaborative care and education. And he is a Canadian physician and a Canadian astronaut and is now a healthcare administrator, actually. And what he taught us from being an astronaut is that you have to teach people to be leaders, absolutely, but on any team you have to teach people also to be a follower. And when you're a leader and when you're a follower, and that's part of the education that I think we really need to implement.
That's exactly what I was going to say.
And Glenn, as a patient, do you know when to be a leader and when to be a follower? Because you made an important point at the beginning. You said patients have to take responsibility too. We don't always talk about that. But do you know when to lead and when to follow?
I think I do, because I've spent 30 years working in healthcare, and I've been on both sides of the bed, and I think that at this point in my life, I'm aggressive, and I'm not afraid to ask questions or to jump in and take a leadership role. Not everybody is at that stage, and I think that in some situations, patients and families have to be encouraged and coached in order to be able to take on a leadership role or a more aggressive role in getting their questions out and answered and being part of the team.
So if somebody messes with you, they've got tire tracks.
You
on
got
the
it.
back. Okay.
Absolutely.
All right. So Rosalind, jump in quickly, and then I know we have some questions coming. You're good? Okay. So go ahead.
So I know I'm supposed to direct my question to specific people, but I think that I'm interested in hearing different perspectives. Mainly, I think, I can't really...
Throw it out and we'll decide who
good.
to throw it to.
So it has to do with the continuing of care. So we know that healthcare is not an isolated experience in a hospital, in home care. We know there's an entire continuum of care. And what would you suggest if you're working in an organization that is patient and family centered, and then you're then interacting with the next step in a continuum of care where the organization is not necessarily patient and family centered?
So Cynthia, why don't you start with that one, because I know I heard this in your session. A lot of our discussion has been around clinical and hospital care. What about interacting with all these other groups, home care, social workers, everything, and they're not necessarily, they haven't bought into this concept yet. How do you deal with that?
But I would tend to disagree, because they have been part of our model of care.
But let's go
KGH.
theoretical, you're somewhere else and they haven't bought in. What do you do?
I think because it's becoming an expectation of our patients and families, it is something that may be forced upon others, and it's not a new concept. Everybody has heard about it at some point, so I can see it spreading across the continuum of care. I don't know how you change the resistors. Maybe somebody else here has a suggestion.
Rosalind?
Well, I just wanted to add that, if a patient is in the hospital and they're moving to the next level of care, such as rehab or nursing home, and they're not a patient and family-centered care, patient and family-centered care is not the philosophy of their organization, my suggestion would be to get out there and educate them about what patient and family-centered care is, because we're going to be partners in care. I'm going to be sending patients from my facility to your facility, and let's collaborate on the continuity of care here. And if that's our philosophy, and then share with them what the benefits of patient and family-centered care have been at your hospital, and then they'll begin to see what the rewards are, and hopefully they will embrace PFCC, patient and family-centered care.
Okay. And Carrie, do you want to talk about that? How do you deal with that as a patient or a family member when, one part of your care is great, really patient-centered, and they're wonderful with you. Then you cross the street or go down the hall, and they're like, "Hey, we don't want to, keep quiet." How do you deal with those differences practically?
Well, when that happens, and that does happen a lot, really you try to learn the best way to manipulate the next care provider to get what you need. And I say manipulate in a positive sense, not a negative sense. Sometimes it's just learning what is the trick to get them to give you what you want and need. That takes a lot of time and energy, but it's worth it. That's really a short-term solution. But I really think that as you grow, the patient and family experience advisors that you have, they live across all of these continuums. And you can bet that they're going to identify where all those gaps are, where the changes are, where you get really, really good service, where you really need people to have a lot of growth. And patient and family experience advisors, they want to do it all. We want to help every component of the healthcare system be as good as you can imagine it being. So build your cadre of advisors, and that's just going to spread. That's just the way it's going to be.
And Leslie, on the education front, how do you deal with that? I go to lots of hospitals, and you see a different culture sometimes from ward to ward. How do you teach your newbies to go in there and resist that culture and do the right thing when it's old-fashioned and et cetera?
It's a very good question, because our learners, as they go into a clinical care setting, they will, as you say, be exposed to many different patterns of care. What we're trying to do is the same thing as empowering our patients. We're trying to empower the patients to have a voice. We're trying to empower our learners to have a voice. And if they see something and hear something that really is in contrast or contradiction to what we've taught them, we encourage them to ask a question. I wonder why this is different from what I expected or anticipated, or I learned it was going to be like that. It's a bit about challenging the people with whom you work with and the environment that we're putting our learners into. Easier said than done sometimes, but that's what we're trying to do.
Well, I'm going to come to you in a second, Bernard, but I want you to address that, Carrie. It is easier said than done. A lot of patients are afraid of talking back to their healthcare professionals. Oh, they're not going to change my bed. I'm going to get the crappy Jell-O. There's going to be all kinds of... People are afraid. Well, maybe there's no good Jell-O. It's not a good example, but people are afraid there's going to be repercussions if they speak out. Is that still the case?
That's very true. People are very afraid that if they challenge their providers, not that the providers are going to punish them by neglecting them, but that through unease, the relationship will continue to deteriorate. And I think patients and family members are also somewhat frightened of this new thing that we call patient and family-centered care, because we talk a lot about the responsibility then that patients and family members have for their own care. And that terrifies me if it means I have to become the expert in my care. I'm not the expert. You're the expert. I think the piece we have to really focus on is how patient and family-centered care builds on the expertise that continues with all of the medical and other support staff that are there. It's not instead of, it's not different from, it's an add-on to continue to enhance that. And I believe that our patients are really going to need a lot of support and subtle training to begin to develop their skills at becoming better patients. You know, there's a whole generation, my parents' generation, won't ask a single question when they go to a medical appointment because that's the way they were raised. You folks were the experts, you knew it all, and you would cure them because of your high knowledge. My generation, it's still hard for me to go in and ask questions and challenge. I can do that by thinking ahead of time, but you know, if it's an emergency and I'm on the spot, I retreat back to the way I was brought up, which was don't question the expertise of the experts. I think the younger generation brings a different set of practice with them. So time is going to help us resolve these things if we stay on this path and continue to reinforce that this is in addition to supplement and build on the excellent care that we get.
Great. So Bernard, jump in there, and then I see we've the audience has come to life. We have a whole bunch of questions.
Well, the one thing I just wanted to say was that families will now ask if where you're sending me is a patient and family-centered organization, and if it's not, can you talk to them before I get there? And we have done that when we were looking at contracting for our palliative and hospice care. We put out bids, and so we had patient advisors as a part of the group that was looking at the bids, and they literally said, if they're not patient and family-centered, can we have in the contract where they send us back to you? So, I mean, they're asking this, and the company that actually got the bid asked for training because they knew that was going to be one of the things that needed to take place. So we actually provided training for all of their staff.
So can you leave us a phone number and we'll have you make some calls for us? Okay. So I'm going to go here and then there and then there, and well, I'll try and keep quiet. So go ahead here.
This question for Bernard, and it's to tap into your experience in the States. Can you tell us a little bit about how your organization has partnered with the university and how they are approaching education, and what impact, if any, it's had to university and to your organization?
Okay, well, I can't take credit for the tap into our university. That actually started with Pat Sadomka, who was our champion, when she actually created the Center for Patient and Family-Centered Care in our organization to ensure that our students, we actually have 5 colleges in our university system. Well, now we also have a liberal arts college because we just merged, but we have 5 colleges for healthcare in our university. And she wanted to assure that education on patient and family-centered care was a part of their curriculum. And so we started providing lectures into the college, but we also started providing what we call family faculty, and that's where our patient advisors actually go into the classrooms alongside of the instructors or the faculty, and they teach about their experience of care and what does it mean for a physician to provide care to our patients, and what our patients actually are looking for when they come to the doctor's office. And so we've been able to expand that even more. We're into even more of the classes, but just recently here, actually within the last month, I met with a group of the medical students, first and third year students, and now they are petitioning to have patient and family-centered care as a class, as a standing class, as a part of their curriculum, so that they will get it on every year. They want to get patient and family-centered care every year. They said getting it bits and pieces in individual lectures and getting it, first and third year is not enough. In order for us to maintain that standard of practice, we need to have it every year. So they've gone to the dean and the other leaders in our university to say, this is what we need, and we need this in all of our health sciences and health education courses.
So Leslie, how about a patient family-centered care class at Queen's? Is that coming?
We don't call it that, but I think in terms of interprofessional education and the principles, which is about valuing the patient and valuing the family, I think it's not labeled that. I think it's very much implemented.
Good. Oh, good. So I thought somebody was at the back. Somebody at the back, Mike? Oh, yeah, you are. Go ahead. But it wasn't you before.
It wasn't me before.
Okay, jump in anyhow. I thought I was losing my mind, but okay.
No. My name is Ivana Popescu. I'm a project manager with the Canadian Patient Safety Institute, where I work with the Patients for Patient Safety Canada program. And I would like to begin by congratulating the organizers for bringing this wonderful group of people together and creating this exceptional energy. One of our members defined it as Niagara Falls, being guided now to provide a societal benefit that generations after generations will take advantage of. This is what I see forming, a new Niagara Falls of patient engagement. I have 2 questions, and I'll let you, André. Thank you. I will let you direct them and maybe choose one. The first one, I heard a lot about barriers for patient engagement. Old dogs, fear, leadership, followership, scheduling, power plays, and so on. But I didn't hear too many people talk about money. So I would like to hear from you about the costs and benefits of engaging patients. And my second question is, what would you wish would be available at a Canadian level for for leaders and people like you as a resource to tap into as you go on your journey to engage patients. Thank you.
So Bernard, I know you talked about this in your session, so doesn't this cost money? How about the money question?
The practice of patient and family-centered care to me does not cost money, and I'll tell you why. My budget does not, there's no resources for it. We took simple things that you can do to implement patient and family-centered care, and that's what we focus on. We focus on those 4 principles. It should not cost you money to provide dignity and respect to people. It should not cost you money to provide information that people can understand. And it should not cost you money to ask people to participate and make them feel welcome. And it shouldn't cost money just to collaborate, to talk and change your systems, look at your policies, look at your procedures, involve patients and families in interviewing. So my budget is very limited, and the way I actually fund patient and family-centered care, I had to take on other departments that did have money. So they don't give me money to go with patient and family-centered care. I use monies from the other departments that I had to take on.
Now, does it save money?
It does save us money. I'll give you one good example. When we were buying beds a couple of years ago, and the staff, they were down looking at the beds, and oh man, it had to have everything. It had to have the radios, and it had to have GPS systems and all of that other stuff that people look at. But when our patients and families got in the beds, they came to look at the beds. They got in the beds. They made sure that the controls were where they could reach them. They made sure that the bed lowered far enough that if they sat on the side that their feet were on the floor. They looked at the practical things, the things that we didn't think about. We wanted to make sure it would go through the doors and wheel just right and those kind of things. And so the beds that our patient advisors chose were actually a whole lot cheaper than what our staff chose. So yes, it did save us money. It saved us money when we were doing renovations, because all those big things that we thought patients would like, the Ritz-Carlton type things, or what do they call them now, high-end things, patients didn't want that. They wanted to be comfortable. They wanted us to use those monies to make sure they got great quality care. And so, it does save money.
And Glenn, I'll reframe the second question and put it to you. Say, I sit you down in front of a CEO, not Leslie Thompson, say the anti-Leslie Thompson. I don't want to know anything about this, it costs too much money. How do you convince them that this is the right thing and it's not costly?
Well, I think first of all, we have to get across the point that as a patient, I want to be treated with respect and dignity. And I think that that's really critical in everyone understanding that that's the basis we're coming from. I think that what we would want to do is to talk about the benefits of the patient to the patient. And the whole reason that the hospital exists is for the patients. So if we could tell them and explain to them what we see as benefits from moving to this model, I think that would be very, very beneficial. I'm sure there would be lots of resistance. I think that, again, what you need to do is you need to look within the organization to see if you can find some champions and have those champions work with you to convince or to show in some way that making the change is really very positive, and that in the long run it can save money, because of the impact of having the patient involved. It can be perhaps earlier discharges and reduction in medication errors, etc. So there are lots of benefits that can come out of this. And I think it's also pointing them to the reality. I mean, this is coming. Let's face it. This is the direction health is going. And you're going to have to, you can't stick your head in the sand. You're going to have to, at some point, come on board. So let's do it now and be positive about it.
Sounds like we should send you on a tour of a few Canadian hospitals. So yes, you've been very patient. Go ahead.
I'm Jennifer Chambers. I am coordinator of the Empowerment Council at the Centre for Addiction and Mental Health. And previous questioner actually asked my question, so I'm just going to tell a little good news, bad news tale, which is a number of years ago, every provincial psychiatric hospital in Ontario had an independent funded patient council consisting entirely of people who had received services. And unfortunately, when the province divested them to community boards, 8 out of the 10 hospitals took the money and the independence away from the councils. There are, however, still 2 remaining, and we are fortunate enough to be one of them. And we've been able to succeed in wonderful things, partnering with the centre, reducing restraint use, developing a Bill of Client Rights, doing all sorts of education for staff and clients. All the uniformed police officers in Toronto were educated by our little 3-person council. And we actually were credited in the House of Commons with changing part of the criminal code. So we've managed to do a lot. And I just found out last week that the members of the Impairment Council threw off for study because people were being interviewed about the burden of mental health and addiction. They said the people involved with the council have had too positive an experience and they're throwing off our our results. You need to try and find some people that aren't involved with you. So it's not just when we're doing this work, we don't just benefit other people, it also benefits us. Thanks.
Thank you. Thanks for that story. Let me flip that into a question for you. Maybe I'll ask Carrie. Is patient-centered care for everyone, or are there some groups where, and I hear this, it's a little too difficult, people with mental illness, older people, if you have cancer, you're a bit too sick. Some people say, well, the old style is good for some patients. Is that correct, or is it for everybody?
No. It's not correct.
Oh, I thought you were saying it wasn't for everybody. I thought I had a story here.
It's absolutely for everybody. Patients who enter the hospital system are not there for 100% of the rest of their lives. They spend most of the rest of their lives out in the community. And the better prepared that they are to be successful in the community, the less frequently they're going to return into our healthcare system. So I think it's those maybe marginalized and high-risk groups that really need some dedication and some focus to figure out the ways that are effective and in terms of engaging them. I would be shocked if any members of those populations said they don't want to be engaged in patient and family-centered care. Imagine if they were to say in mental health, we don't want dignity and respect. Imagine if they said in oncology, we don't want information. I mean, honestly, the question is ridiculous.
Okay. Point well taken. Thank you. So,
hi there.
Now for a non-ridiculous question. So we have.
I'm Rita Foreman.
Last 2 questions.
Director of Patient Experience at Trillium Health Partners. My question is about what we all want as far as patient and family-centered care is for the words visiting hours to disappear. And one of the pushback conversations I've had is with the security department. And what's been conveyed to me is, when we had SARS, actually, the nurses really liked it because SARS was a respiratory illness that kind of swept through. And we shut down visiting hours at most hospitals that were infected with it. So he said the nurses loved it because they could get all the work done. And there was no interference from families and patients being kind of interrupting things. And then my question is to our American friends is, the latest conversation I've had with the department, the security department, was since the very terrible events in Boston, well, now security's got to even tighten up more at hospitals because that's just such a vulnerable population for some sort of big event, like big threat like that. So my question is, has it? Is it something that you look at differently when there are things like bomb threats that you hear about even in other parts of the country? I don't know. How do you deal with that security piece?
Well, first of all, at our hospital, we've not experienced that. We're a level 1 trauma center, and we have a very high population of gangs in our area. So sometimes you can equate gangs with terrorists. And we have gang members who are right next door, to one another in our shock trauma unit. And the one thing we haven't done, fear is going to be there. And you do have folks, our security has said the same thing, we need to lock the doors, but not on my watch. They're not going to lock the doors. If our patients and families say we would rather have the doors locked, then we'll lock the doors. But there's not a real threat. There hasn't been a real threat. And I do have people that come to me and say, the nurses are fearful of their lives because you've got all these things going on. And I do take that very serious. But the first question I ask is, what has happened in your unit to make you want to lock the doors? Well, nothing. We're just anticipating. Well, why should I keep family members out because you're anticipating something that might never happen? I mean, and we've had open, no visiting hours now for at least 10 years, and nothing's happened. So, we try to address their fears, and we really do take it in consideration. And there are some times that we have to lock the door, but there are guidelines behind that, and we set those guidelines with our patients and families. I don't want there to be not one family member that doesn't get in to see their loved ones because somebody's afraid. Because I hear in other hospitals when I go places where they say, I was sitting outside because they had the doors locked and my husband or my wife or my daughter passed away and I didn't get to say goodbye. So yes, I take it seriously and I do listen and we do talk about it, but unless there's something seriously that's happened, no, we're not going to lock the doors.
Now, Cynthia, you got rid of visiting hour restrictions. Was there pushback from security or elsewhere?
There was a lot of fear when we made the change. We've had in 4 years or over 4 years now very few incidents, and no, we didn't have pushback from security. And it's been really positive. People will go home because they know they can come back at any time. So whereas before we needed security at the end of, at 8 p.m. to go up and down the house to try to get people out. That doesn't happen anymore.
Great. So we have one last question. Go ahead.
A question to Rosalind.
He's trying so hard.
Question to Rosalind. Rosalind, here we have Accreditation Canada. I think in the States the Joint Commission is the same. Do you have standards for patient and family-centered care?
Yes, their Joint Commission has adopted a standard for patient and family-centered care. So for those facilities that are not on board, they will soon be on board to be in compliance. So we are very welcoming patient and family-centered care throughout the U.S. of A.
Okay. So by popular demand, ask your question, but stop sitting down and standing up. Just stand up.
Can I put on a disguise? Jeez.
No.
So I'm really, as you know, into the cultural issues, and culture in this context, like things that keep things from changing, is the set of shared expectations about what's appropriate behavior, right? And what I hear over and over in what you're saying is that it makes a difference when somebody speaks up or when they're not willing to. Right? And that shows up in the form of people resisting change by saying, well, my patients aren't asking for this. So I want to know, you Georgia Regents people, what have you done to get patients speaking up? I see parallels with feminism and civil rights where, you start to speak up and you get smacked down. Well, there comes a point where your back stiffens, right? As a patient, what do you do to get people to speak up?
We actually had a campaign throughout our whole facility that called Speak Up Campaign. How about that?
Some things are complicated, some things
That's
are...
right. That's right. And we educated our staff to speak up. We educated our patients and families to speak up. So throughout our whole facility, you will see signs that say, speak up. We want to know what's on your mind.
Could you send those? Yeah, that's wonderful. Great,
yes.
Thanks.
So before we wrap up, I want to each of the panelists to have one last chance to speak up. I want you to give just a one-sentence, pithy, the message you want people here to take home So Bernard, you've got the mic. Go ahead and start. So give us your best zinger.
Well, the one thing that I'd like for you to take home, really, and it's been resonated throughout the conference last night and today, is to truly make the 4 principles of patient and family-centered care the basis for everything that you do, and you build upon that, and you just make that a part of your everyday life, and you hold each other accountable in your organizations for making sure those things, those 4 principles, are with everyone.
And repeat them again, please.
Dignity and respect, we put them together. Information sharing, participation and collaboration.
Great, that's 5. Okay.
My biggest takeaway that I would like for you to have is don't wait to get started. Get started now. The first step in change is to increase urgency, so we should all leave here feeling that sense of urgency to go back and make a difference. Just as you were saying, go back the next day and get started. Just do it. And no matter where you are, no matter what department you work in, know that you make an impact on our patients and families each and every day. And always remember, this could be your mother, your father, your sister, your brother, your best friend, and what you would want for them, that's what you should want for your patients and families.
Thank you very much for your attention today. I'd like to finish by just saying that I think there's much room and reason for hope and optimism, given the tenor of this conference, given the young people with whom I'm working in terms of their education now, and interprofessional education is about learning with, from, and about.
I'd like to say how amazed I am at this hour on a Friday afternoon. Look around and look at the group that's here. Everybody is so deeply committed to this. It's not going to go away. The one piece I would challenge you to do before you leave today is, if you've come with someone, then make a pact with them that before 1 week from today, each of you will have done something that's patient and family centered, not focused, centered. And if you've come by yourself, make a buddy and keep each other honest. But the time limit is 1 week from today.
Wow. I think what strikes me is that as you move forward and are making positive changes, to really include the stakeholders, and I mean all the stakeholders, including the patients and families, as often as possible and as early as possible in the transformation.
I think the one key thing is in relation to interprofessional education, and I think that by including everyone in that whole process, it brings about a stronger team. And as a patient, I want my team to be connected. I want them to know where we're going as a group, and I want them to feel part of that particular group. So I think that interprofessional education process can help move in that direction.
And please join me in giving our panelists a big hand as we make our way out. Thank you.